Hi everyone, and welcome to tonight's webinar. It is called General Data Protection Awareness and an Overview of the National Medicinal Product Catalogue. My name is Emily Kelly. I'm one of the peer support pharmacists, and I'm also a community pharmacist with Macaulay's in Dublin. So the domestics of tonight, this webinar will be recorded. Please mute your microphones. You can turn your videos on and off, whichever you prefer, but if they're on, they will be part of the recording. If you experience any problems with connectivity, sometimes it helps to turn off your video, or if you're having difficulty with the sound, have a look at the speaker is not muted or turned down on your computer. And sometimes if you log off and log back in, that can help as well. For questions tonight, you can put them in the chat box throughout the presentations, and at the end, the panel will answer all questions that we have that are there. And some of the information may be used in an anonymized form after the webinar. So without further ado, I'm going to introduce you to tonight's panel. So we have Elmarie Cottrell, who's the HIMSS operational lead, Chief 2 Pharmacist, Acute Hospitals Drugs Management Programme for the HSE, and Elmarie will do a short introduction. Then we have Mary Deasy, who's Data Protection Officer for the HSE, who's going to give us a generalised talk on data protection and the importance of GDPR in terms of patients. And if you have any specific queries for Mary, you can also pop them in the chat as she's speaking and throughout the night. After Mary, we'll have Byrnes, who's Clinical Lead National Medicinal Product Catalogue for the HSE. And we also have Brid, Clinical Lead for ePharmacy and Chief 1 Pharmacist for the HSE, also on the call, who will wrap up and put the context of all the presenters together and be available for the chat, the Q&A at the end. So without further ado, I'm going to hand you over to Elmarie. Thanks very much.
Thanks very much, Emily. Good evening, everyone, and thank you all for taking the time to join this webinar this evening. My name is Elmarie Cottrell, and I'm a Chief 2 Pharmacist with the AHDMP, and I currently work in the area of health informatics as the HIMSS operational lead, which is an e-health project within the HSE. So what is health informatics, and why are we holding these webinars around this topic? So as you're all aware, digital health is a crucial enabler in delivering healthcare. It offers innovations, solutions, it improves access, efficiency and quality of care. And a comprehensive digital health investment is imperative to address the current healthcare challenges that we're facing within the Irish health system, such as rising costs, siloed systems and increasing demands for services. Leveraging digital technologies will change healthcare delivery, optimize resource allocation, and it will empower patients to actively participate in their own care. Healthcare, or clinical informatics, is the use of information technology within our healthcare system to provide clinical care, and it's one of the fastest growing areas in health. Currently, there are 2 webinars scheduled in the area of health informatics, with the objective of these webinars to make people more aware of the current digital health projects that are ongoing, as well as providing people with an understanding of some of the basic terminology and the concepts used in this area. Next slide, please, Shane. So this slide presents a snapshot of some of the digital health projects that are currently ongoing in the Irish healthcare system. And as you can see, there are a huge number of projects in both primary and secondary care, from a new critical care information system to an integrated community case management system. And the products of some of these digital technologies are being seen out in the community pharmacy already. For example, some of you may have encountered some of the prescriptions that are coming from the maternal newborn clinical management system, which is the EHR, which is currently being used in 4 maternity sites in Ireland. Brid, my colleague who's on here tonight, is currently leading out in the development of the National e-prescription service. And there's also a move to electronic health records in private hospitals. So, for example, the Bonds Connect project, which is hoping to go live in 2025. Approximately 30% of the world's data is generated by the healthcare industry, and this is expected to rise significantly, up to 36% in 2025, and keep growing. Data is a core asset of the healthcare industry, and e-health will result in an increase in the volume and the accessibility of data. So Mary Deasy is the DPO within the HSE, and she's going to speak to us tonight about data protection and awareness, a topic that's really important with the advancement of digital technologies. Byrnes is the clinical lead for the NMPC, and he will provide an overview of the work that he is doing in this area. And the NMPC is a critical project to support semantic interoperability, or the flow of medicines information through all of these systems. So I'm now going to hand you over to Mary Deasy. Thank you.
Thanks very much, Mary. So thanks very much, everyone, for coming this evening. So my name is Byrnes. I'm the clinical lead for the National Medicinal Product Catalogue, and we're just going to give you an overview of the NMPC this evening. So just for this evening, I'm just going to go through the role of information standardization and medication safety. And then leading on from that, then we'll kind of look at, what is the National Medicinal Product Catalogue and what are our objectives, and then what will we be doing to reach these objectives. And just to pick out some examples, then we talked about maybe potential uses for the NMPC or information in pharmacy processes. So looking at processes that might support pharmacy activities such as information transfer, the use of standardized descriptions, on-screen selection of medicines, and linking medication activities to outside pharmacy practice as well. And I'll just give a quick update on an open consultation we have underway as well. So just before I want to get into detail of the National Medicinal Product Catalogue, I just want to talk about, the general impact of standardized information and the impact it can have on medication safety. So I just want to look at two examples, one from more local level in terms of local implementation, and the other then from more national level implementation. So the first one is just looking at an example, taking the Institute of Safe Medication Practices, which essentially grades some of the more commonly used interventions in medication safety, and it really grades them, in terms of being the lower leverage or the kind of least effective up to the higher leverage or more effective interventions. And it's graded them looking at the idea that sometimes we traditionally use the least effective, or which are the easier to implement interventions. So the likes of educational programs or kind of suggestives in a pharmacy practice. But it's just really highlighting that actually the most effective ones, even though they're the hardest to implement because they required system change, can be the most effective. So the idea of forcing functions or automation and computerization. So these particular ones really focus on the human errors that require system level interventions, where we're looking to design out the hazards through this automation and forcing functions. So that might be the idea of trying to prevent transcription errors, drug name search requirements to avoid maybe lookalike product name errors and drop-down menus, the introduction of just-in-time alerts or prompts to check for maybe patient allergies or expiration dates on medicines. So just using a common example here at the top, just use methotrexate as a very common example, where it's, the drug itself is highly important in terms of high-risk medicine, but also the route and the dosing interval is highly important as well. But the idea is that by having standardized information that's coded, it enables various systems to implement these forcing functions and the automations to support these patient safety initiatives. So just looking at a different example then in terms of the impact of standardized information, looking more at national impact. So there's building evidence around the positive impact of digital health and e-health solutions on the healthcare system. But there's less research going on in terms of the impact of information or data standardization, particularly in the medication space. But last year is quite a significant piece of research completed in the UK, where they took a very much a national level view at trying to assess the impact of what they call information standards notices. So these would be notices that are sent across the NHS, where they set out policies around information standardization. So keep in line with the WHO's identification of transitions of care as particularly high-risk areas for patients. This large study looked at admissions, discharges, but it also looked at actually transitions of care within a hospital setting and between various hospital settings. So it actually found that the information standard notices reduced medication areas across all of these transitions of care. The relative reduction was lower on discharges, but in other areas there's almost a 50% relative reduction in the actual recording, or the picking up of medication errors when they looked at medicines reconciliation that was completed before the introduction of this standard information and after these interoperability standards as well. So it's very much they tried to take the baseline where systems were in place already. So trying to make sure that the only change was the actual knock-on effect from the information standard notices. I suppose more importantly as well, this study just found that it wasn't just a reduction in actual notifications of medication errors. We know that some medication errors will be preventable, some won't be preventable, and there's a large gradient as well of what can be harmful and not harmful in terms of medication errors. But this study also found that the standardized information led to a reduction in patient harm from transition of care medication errors, led to a reduction in excess bed days due to harm and associated costs with this, and also a reduction in deaths due to harm. So I suppose that's just looking at the information standardization at a very general level. So when we look at the National Medicinal Product Catalogue, we're very much looking in Ireland trying to get a national medicines information standard across all healthcare settings. So I suppose making available the idea of common coding and common descriptions for medicines. So common descriptions, what's available to view on a system, and common coding, what's machine readable, what the computer systems understand. And it's very much trying to associate that with a common medicinal product information. So additional medicinal product information like doses, routes that can be standardized at a national level and support these type of initiatives as well. And I suppose with the National Medicinal Product Catalogue, we're not really focused just on the actual data itself, but it's actually a national service around this to support users to enable integrated medicines management. So the various projects are underway. It's working with them to support them to best use the NMPC to I suppose label and deliver their use cases. So our target benefits from the NMPC are improved patient safety, improved patient or user health experience of the healthcare system, improved healthcare worker experience, and improved use and reuse of healthcare data. And so I suppose in terms of the practice, in terms of how we try to apply this, or what I suppose process we undertake in order to actually support this. So it's really, I suppose, applying standards in everyday practice. So there's an increasing amount of standards both at a national level, EU level, and global level. And it's very much for the medicinal product information, trying to pull these standards together in a usable, accessible format for end users across the healthcare system. So I just gave them some examples there up the top. So SNOMED CT is the global language, because it's global language of healthcare. So it's the largest clinical terminology coding system available globally. So that'll be our underlying clinical terminology, but we also associate this with other information standards such as GS1 in terms of barcoding and traceability, identifying medicines as they go throughout the supply chain. HPRA is the medicines regulator, sets out standards in terms of information sets as well. And just highlight, there's a lot of EU standards ongoing. And one example there is EDQM, which sets out standards in relation to a lot of ancillary information around medicines, such as the routes of administration or dose forms as well. So what we do is we try to collate all this information together and make it accessible and usable in format for all the different users across the healthcare system, whether that's community pharmacy, general practice, acute hospital settings, specialist services, private healthcare settings, or residential care settings. And these are just a sample set of some of the healthcare settings that might use it. So it's very much, again, like I said before, it's working with the end users so to get the best use out of this information to support their patient safety use cases. So I just wanted to talk about some of the examples where the National Medicinal Product Catalogue will support, I suppose, local use cases. So the first one I kind of picked out is the idea of information transfer. So this will be, I suppose, a very common example of what people be used to in terms of a patient that spends the vast majority of the time in primary care. This might be on one or more medications, and they attend their community pharmacist on a monthly basis. They enter a GP on a regular basis as well, and that's where they spend most of their time. But every now and again, they require admission to a secondary care setting. So it's just recognizing that the patient will move into secondary care. In terms of medicines management, they may get a medicines reconciliation on admission to check what medicines they're on in primary care. But as they move throughout the hospital or move onto the ward, they'll interact with prescribers who may prescribe new medicines, may prescribe the medicines they were on in primary care to continue those, or may make adjustments to their medicines. This information will be have to transferred within the hospital to the dispensary, and it will have to be brought back to the ward then for in terms of administration for the medicines. And one particular patient may be moved across different settings within the hospital several times, or may during their acute care journey may go through this cycle multiple times throughout their stay. And then at the end of that stay, then there's the hospital discharge, which again, it's the patient is moving back into the primary care and back to their community pharmacist and their GP in terms of their long-term care. But I suppose this is really highlighting at the moment, the patient, if you look at the grey areas, the patient moves across these care settings, but the medicines information doesn't always move with the patient. So it's really, I suppose, standardizing the information that's available across all these individual settings, across all these individual systems, to enable the opportunity for the actual information to be coded and standardized so that it can be transferred across the various systems and move with the patient as they move across the healthcare system. The next example I just wanted to give was the idea of nationally standardized descriptions. So we know that medicines descriptions, medicines information is used in an awful lot of different ways for different particular settings. A lot of times it's optimized for the local use case. And a lot of times when it's implemented in digital systems or technologies, that there's restrictions around the technology in terms of what can be displayed. And a lot of times it's trying to optimize within that particular technology as much as possible. So within the National Medicinal Product Catalogue, using like SNOMED CT as an underlying clinical terminology, the idea is that we'll try to standardize medicinal product descriptions with a particular focus on medication safety and with a particular focus for the clinical healthcare setting. So not optimize it for a regulatory environment or any other environment, it's optimize it for the healthcare environment. And I suppose it's really, making sure that that information is available again in a coded manner, but in terms of the display of that information, that's available to support various use cases where standardized descriptions may support implementation of digital health technologies. So I just gave them kind of 3 examples there, where the likes of standardizing units of administration or units of strength. So the example there, heparin was associated, it might be abbreviated to U, which might be less than ideal. So the idea of standardizing the actual units of strength as well. A drop-down list which might have particular medicines which are look-alike or sound-alike medicines on one single list, and the idea of abbreviations which may happen regionally, locally, or at a very local level in a particular clinic. There might be abbreviations that are used, again, which might be less than ideal. So the idea that there be a nationally standardized name that's optimized for the clinical health setting available to use as well. And this is just giving, I suppose, kind of 3 examples in terms of selecting medicines on screen. So the idea that by coding the medicines information, it makes it more open in terms of the more available to the technologies to use better. So just the examples given here is kind of starting at the top, the idea that if you had a cyclovir topical applied 3 times daily and it's all free text, that if you talk about selecting a pharmacy, selecting a particular product, that any particular product could be selected. But the idea of adding coding to that information enables actually new technologies to be used and applied to apply constraint to actually help with the selection process. So the idea that a cyclovir could be coded, so all the particular products and brands associated with that particular drug could be displayed by default. So the idea of helping support prevent drug errors. Again, by, I suppose, maturing that coding system, that you can actually use coding to route administration as well on the bottom. So the more coding is used, the more options, I suppose, for the digital health implementations. So with the bottom option, the idea that during the implementation of technologies, that there could be the option to restrict the particular products to be selected to a cyclovir products, but also the topical route as well, which supports the prevention of drug errors, but also route errors as well in terms of administration. And I just wanted to give, I suppose, kind of 3 smaller examples just to show, particularly in other countries where they've used their national medicinal product catalogue to support not just moving information within the healthcare setting, but also connecting the healthcare setting to, I suppose, into environments around it, just recognizing, particularly when it comes to medicines, it doesn't exist in isolation in the healthcare setting, that it interacts with other environments as well. So just the example on the left there is from Australia. So it's the Australian medicines terminology, where they've done quite a lot of work in terms of just recognizing that the supply chain, in terms of the medicine supply chain, is critically important to the delivery of healthcare. We know from increasing amount of drug shortages, it can have a disproportionate effect on patient safety in terms of the impact on decision making. So recognizing that actually not just using standardized information in the healthcare setting, but make it available to other sectors as well, can support the actual delivery of healthcare. The middle example there is the yellow card reporting in terms of adverse drug event reporting from the UK. So they've done quite a bit of work with their national catalogue, the drugs and medical devices catalogue in the UK, where they actually use the actual standardized information to try to automate the actual reporting from community pharmacies. So the idea of generating the information, so instead of the community pharmacy manually filling out medicinal product information, that it can auto-generate these reports for them and support the uptake and use of yellow card and adverse event reporting. And the third example there, which is actually quite important, is the idea of interacting with patients as well. So just recognizing that in terms of healthcare, a lot of patients spend most of their time at home, and there's, I suppose, increasing focus on the actual patient input to their care, and the, I suppose, patient increasing their use of healthcare information to better support their decision making. So this is just an example in terms of a European project which uses standardized medicinal product information to support the delivery of patient apps as well. So with that, then I just wanted to highlight, I suppose, at the moment we have an open consultation available that's open for feedback at the moment. So it's around our kind of, I suppose, our data set and the information we have in the National Medicinal Product Catalogue, and we would welcome any feedback. So we're just asking if anyone's interested in that. If you want to email nmpc@hse.ie if you're interested in providing feedback, and that's open until the middle of April. So with that, then I'll just hand back to Brid for Q&A.
Lovely. Thanks, Shane. I think Emily is going to handle the main part of the Q&A, but I suppose what I was just going to say is thank you very much to Shane and Mary for presenting this evening. I suppose the idea for taking one or two of the IOP sessions came with Elmarie, Fanula, Shane and I kind of chatting about, thinking about some of the building blocks that we have for digital health programs. And certainly when we look at the presentations here tonight, it's looking at what are those building blocks for how we can accurately share information, which I think Shane has gone through, like how the NMPC will be able to help that, of getting that accurate sharing information to the right person, to the right place at the right time. And that links us back to Mary's kind of talk around data protection, of making sure we have the lawful basis to do that we do it safely and correctly. And as we move along with the National E-Prescribing Project, I will probably be tormenting Mary with the DPIA of when we think about what happens as we move into a more digital framework of what information are we sharing, to make sure that things aren't too accessible and that we have that privacy by design, so that all the staff within their different organisations are appropriately trained and consider that data protection. And I think we need to remember it's always complex in the Irish healthcare setting. We don't do anything easily as we work between that public and private mix of healthcare. There are, I suppose, different authorities that we report into. There's different structures. There's even different data controllers and data processors, as we realised from Mary's talk. So sometimes it seems really easy and lovely when we see the presentations today, but there's those details that all of our projects need to work through. And it's really, really useful to get those reminders with talks like these to understand how we need to keep everything in line as we move forward. But I'm rambling away now, so I'm going to hand you back to Emily, who's looking after the chat and the questions. So anyone on the call can ask more specific questions.
Thanks, Brid. I think it's very quiet in the chat box so far, but maybe there's a lot of community pharmacists like me on the call, and that seems like an awful lot of information, as in probably a lot of, it's very new to me, and not the data protection, but seeing it all, I suppose it's a lot to process. So I maybe give people a few minutes to think about it. Elmarie, you had a slide at the beginning that just nearly blew my mind with all the things that are going on. And I suppose, you know, we work every day in community pharmacy, and in one sense oblivious to, I just couldn't believe the level of projects out there, and that the maternity projects, the private hospitals, and when do you start thinking we're going to start seeing a change in our daily work, I suppose, or how is that going to impact us?
I think pretty soon, Emily. A lot of these projects have timelines to deliver over the next 2 to 3 years. So if you look at the Bonds Connect project, that is got a target of delivering at the end of 2025. So that will lead to their discharge prescriptions likely being in an electronic format, or in probably printed and paper, similar to the MNCMS ones initially. But then with Brid's project progressing, we'll be looking to the digital transfer of those prescriptions. So some of the projects on that slide are at a stage where they are phase 1 is operational. So the HIMSS project that I work on myself, we've gone live in Galway already. So we have implemented the new pharmacy stock control system in both UHG and Merlin Park Hospital. And we will be rolling out to the subsequent phase 1 sites over the coming months. That's the initial part of the project. We then have a subsequent part to the HIMSS project where we'll be introducing electronic prescribing and medicines administration functionality into hospitals, which is something that I think we've been all waiting for years to see, and community are probably far ahead with regards to, you've been using digital and e-prescribing functionality through the GP software systems for years, but that will see then the generation of digital prescriptions from acute settings, and that will then support Brid's project in getting information from the acutes through the electronic prescription service. It's going to take a number of years for all of these projects to align, but the building blocks are happening, and they're happening very fast. And there's a lot of parallel projects happening. So I think, as Brid mentioned, Fionnuala King, who's the chief pharmacist for the AHDMP, myself, Brid, and Shane felt that it's important that we inform, our pharmacy colleagues of what is happening and make people aware of these projects, because we will see the products of these projects coming very soon into the community setting.
Wow. Yeah, and David has just put in a question: how are IT infrastructures being future-proofed to be ready for the informatics? I don't know who wants to take that.
I suppose I might take a stab, Elmarie, or someone can, or Shane can, they can correct me as we go along. So I suppose, David, a lot of it is that we're looking to what are the newer standards. So it's a case of we need to accept, I think, that Ireland probably isn't going to be the most mightn't be the most groundbreaking place for advancements, but we're looking at what's been done well in other countries. We're looking at what are the emerging standards that we need to use in healthcare. So it's making sure that we have moved on to those. So rather than planning everything on older healthcare standards, that we're looking towards those newer ones that are being implemented around now. And I think one of the ones that is really gaining ground is the likes of HL7 Fire, which is meant to be quicker to implement than HL7 2.4 and more dynamic. But we also need to look to make sure that older systems, and I call them older systems, they're existing systems. So the likes of community pharmacy systems, GP systems are built on the HL7 2.4. So we're lucky to be able to build on the experiences that they have internationally, where they look for compatibility between the two types of standards moving forward. Some of the ways to look is, a lot of it is kind of lessons learned from sites internationally, the likes of talking to the NHS, where they're in a situation now where they have built their e-prescribing really about how community pharmacies and GPs work. So they do what is called a product-based prescribing and dispensing. So that's where generally the GP with prescriptions coming out is selecting atorvastatin 20 milligram tablets, and they're telling you to take one tablet once a day. So where the struggles arrive for them later on is for prescriptions coming out from secondary care, where prescriptions are prescribed atorvastatin 10 milligram orally, and it's once daily. So there's a slight change in how that information is coming in. So it's a case now of trying to look at those primary and secondary care settings to see, can we use the standards that are there internationally? Can we use the likes of the National Medicinal Product Catalogue coming out to see, can we make that information computable between the two systems? So that's one way of looking forward as well, is trying to look at the data sets and the data structures and to see, do they match both primary and secondary care prescribing? And if they don't, it's okay making a decision of, do we need everyone just to do everything the same way, or can we actually maintain that flexibility between what people are used to? So there, I suppose, two examples of where we're trying to protect ourselves for the future, and also build into any procurement what are the future things we think people may need to do. And I think it's really useful that there's work on, a HSE app for patients as well, because I think a lot of our focus here has been talking about healthcare professionals in this, but it is patient information. And I suppose there is a real drive to give patients access to that information again, considering how HealthMail has, I suppose, taken away some of their knowledge of what's prescribed immediately, because they don't always see the prescription. So it's also working for me, I suppose, in particular, it's working with projects like the HSE patient app as well, to see what functionality we can build in that gives patients access to their information early and some functionality with it. I don't know if that fully answers the question, but I suppose it's a touch on it.
Thanks, Brid. Yeah, another one, a lot of learning around IT infrastructure, huge issues with citric acids and access and ICCA in our ICU in the PUH. That's probably very specific to a HSE, is it? And the moratorium on recruitment has a huge impact. No national formula, a huge challenge, as well as matching local and national policies and procedures. That's more kind of, I suppose, a comment in general. Brid.
It is, and I haven't got into the horrors, I think, of citric access, I'm going to say, in some ways. I don't know whether Elmarie has. I'm not sure what the ICCA is, but yeah, I think we are all, I think when the moratorium is affecting, I think, everything across the way. It's affecting projects where people are getting promoted internally. It's affecting people on the front line, where we all know if there isn't, I suppose I've come from working in the secondary care setting, where if you don't have someone to check the patients in, that's a really important function as well, about getting the right wristband on the right patient, making sure that someone else hasn't stood up accidentally from the waiting room. So I think the moratorium across all levels of healthcare it's challenging. It's challenging for those of us internally in the HSE and those in frontline healthcare.
And the national formulary is mentioned there. I suppose, Shane, for my head, and again, it's coming from the community sense with the National Medicinal Catalogue, how will that differ from what we probably do already? Because I suppose I would see we have codes and we use codes, and is it more about standardizing the hospital part rather than the community part, or did I pick that up wrong?
So I suppose with the National Medicinal Product Catalogue, it's very much looking across all healthcare settings. So recognizing that there are kind of, I suppose, local pharmacies, and whether it's primary care or secondary care, but it's very much, if we kind of go back to that image of Mary on our journey, that idea is we want to support Mary whether she needs to go to any healthcare setting in primary care or any healthcare setting in secondary care, and make that information available so that that information can flow with her, whether that's an e-prescription or an electronic discharge, or whether it's an inpatient setting in terms of within two various systems. But it's very much, I suppose, looking at the entire scope of the healthcare, so that the idea is that Mary, no matter where she needs to go in the healthcare system, no matter what service she needs to support her, that she can actually, that her medicinal product information can travel with her in a standardized format.
There's another question, Mary, on data protection. I'm a community pharmacist who regularly share personal data as and when requested by other healthcare professionals. Do I need to log these interactions? And Shane, just one last thing for me is you asked for feedback around, I think, what type of feedback are you looking for? How is it on this presentation, or is there a document or something that pharmacists should look at and give you feedback on?
It is, so we actually have a document, so it's on our kind of, I suppose, our data model. So the entire, I suppose, the data set that'll be contained in the National Medicinal Product Catalogue. So if people want to use that email, just email into us, we can send out the document. And like I said, that's open now until the middle of April.
Thanks very much. Emily. So I think that brings us to a close. I know, well, for me, definitely, it was a lot to take in, so kind of a first go at it. And probably the good news is this is a two-part series from the eHealth group. So there's a second webinar on the 8th of May, and Grace is going to share now the feedback probably on this session, but there's an extra question in there tonight, which is saying, is there anything particular you want questions that you want answered, or speakers or topics that you would like covered on that second webinar on the 8th of May. So please make sure you put it in, because the more feedback it is, the more it can be tailored to exactly what the IOP pharmacists are looking for. So thank you so much for your time. We really appreciate it. Don't forget to open up a CPD cycle and pop it in. And any learnings you got from tonight. And the next webinar is on Wednesday, the 10th of April, with Anya O'Reilly and Lorna King from STEP, which is the South Tipperary Enablement Programme for older people. And it's part of the Integrated Care Programme for older persons. So thanks a million to Elmarie, Brid, Mary and Shane.
Okay. Thanks for having us, Emily.
Thank you.
Thanks very much, everyone.
Thanks everyone for coming. Bye-bye.
Thanks. Bye-bye.